Bueno, vamos a ver si ahora podemos conectar, ¿eh? Bueno, estamos esperando que nos envíe la info. Disculpen a todos por las molestias. Okay, Dave, you are, yeah. Please send me the invitation and I'm gonna accept. Please, but send me the invitation. You did it today, but then I don't know. Okay, Dave, you are inside, but now send me the invitation. Gracias a todos los que se han sumado. Dave, you are hearing me? Okay, Dave, if you are inside, look that you have an advice is next to your name and it's for send me the invitation and I'm gonna accept. Siempre hay tiempo para algún blooper, así que no se preocupen. Cosas que pasan, no estén puteando del otro lado, bánquenla un poquito y vamos a poder entrar tranquilamente. ¿Sí? Sí. Acá Alberico me está diciendo que invitalo. ¿Dónde están las cartas? Aguarden un segundo. Las preguntas. Y buscás e invitás. Aguarden un segundo. Un segundito. Vamos a tratar de buscarlo. Ok. ¿Dónde están las caritas? Me dice. ¿Cómo sabés, Alberico? ¿Cómo se nota que fuiste la persona que inventaste esto? Me invitaste esto. Un segundo, que voy a invitar. Dave, 1 second. I'm gonna send you the invitation. Yes, I got it, Dave. Send you the invitation.
Hey,
Hey, Dave.
I was trying to figure out how to send the invitation. Hey.
What was funny? What's funny? Thank you so much, Dave. First of all, thank you for joining us. For us, it's really interesting have the possibility of talking about with you. You know that you are a referent in ACL rehabilitation, but also you are a friend, and I have a lot of respect for you. Thank you so much, my friend.
Well, thank you for having me.
Yeah. Okay, I'm gonna be the translator. I'm not expert talking in English, but please be patient with me. Bueno, vamos a comenzar, gente. Disculpas por las molestias. Como les dije, no soy un intérprete, no soy un traductor, pero voy a tratar de poner lo mejor de mí para que podamos tener una buena conversación y todo el mundo tenga la posibilidad de charlar. Así que, muchas gracias. Thank you so much, Dave. A lot of people are followers now. A lot of people send us very good question for you, but the most important is not just talking about academic. I think that maybe it's really important talking about how are you in this moment. How do you cope with the lockdown?
Good question. Una cerveza.
You are crack. Le pregunté a cómo está pasando un poco la cuarentena y bueno, la está tomando la cerveza, así que creo que entendió todo. I think that maybe you understand everything. You understand everything. How's your family?
We're good. We're good. Fortunately, my wife and I both teach, so we can both work from home.
Yeah. Dice que la familia está bien, que está trabajando en su casa y le quiero decir a Diego que no es que tiene BPP. Le voy a pedir que vuelva a poner el teléfono distinto. Hey Dave, can you move the phone in this position? Yeah?
Yep, back this way.
Yeah, it's much better for us.
Okay,
Thank
okay.
you. Thank you. My friend, uh, first of all, thank you so much. Yeah? We have a lot of questions. I think that maybe for the beginning, it's really interesting to talk about how do you drive this situation, especially talking with your students, especially talking with the participants of the lab, the patients of the lab. How do you drive this situation?
Yeah, so with the students and the other faculty, we're doing a lot of online meetings, so a lot of Zoom.
Ujú.
Go ahead.
Ok, dice que los estudios siguen haciéndolo gracias al Zoom. I think that maybe most people understand the real importance of the Zoom now. It's,
Yeah,
it's really
yeah.
interesting. But for example, I mean that in America, America is very big, and you have each state is different, and maybe yeah, so you have connection maybe with other states. You have a lot of talks with other colleagues in different parts. In Argentina, the situation is different. For example, Argentina is maybe I think that maybe Buenos Aires is like a core of the not just
Yeah.
the country, it's the core of the world for the people that are here. But it's a joke. It's a joke. My friend, it's very good. Es lo que nos está diciendo que están trabajando por Zoom. I have a lot of questions for the direction of this talk. I mean that it's question that there are questions that is for different topics in the ACL rehabilitation.
Uh-huh.
And obviously, maybe you have a patient that the ACL is broke. Obviously, you have to choose a decision. What do you know about, what do you think about the decision, surgical or non-surgical? For introducing the people, le voy a preguntar qué es lo que él cree acerca de un paciente que tiene una lesión del ligamento cruzado anterior. ¿Qué pasa con esto? Tal vez 10 años atrás pensar en esto era una locura. Hoy en día se está hablando mucho más de la posibilidad no quirúrgica. 10 years ago, if you have a patient that he has an ACL injury, you think it's surgical. But now the situation is changed. Now, what do you think about it?
Yeah, so there's a couple of different options, and I think in the States now we're trying to see a lot more of shared decision making. So again, a lot of times we will talk to the patient to find out what their expectations are and what they want to go back to doing and how quickly they need to go back.
Perfect.
Um,
1 second, let me
Yep.
translate. Lo que está diciendo él es que sí, que hay diferentes opciones terapéuticas, que todo depende también de cuál sea la necesidad de la opción, que siempre la decisión tiene que ser compartida y todo depende de la expectativa que tenga ese paciente en volver rápido o volver un poco más lento. Talking about expectation, what do you think about that? For example, you think about the expectation depending the type of sport, or you think expectation depending of how is the characteristic of the patient? How are?
Yeah, it's actually kind of a combination of both. Sometimes we have an athlete that needs to get back maybe for a short period of time to finish out a season. Maybe it's a worker that does seasonal work and he has to finish out the job. So many times we'll consider, high level non-operative treatment just to get him through that stage.
Bien, bien, lo que está diciendo es que depende de las dos características que yo les dije, no solamente el tipo de deporte, también las características de ese paciente y que muchas veces depende en qué momento de la temporada tiene la lesión, si tiene el momento, por ejemplo, al final de la temporada y también depende de cuál sea el nivel de competencia que tenga ese paciente. Good, my friend. Talking about the concept copper, yeah? For example, today, I think that maybe it's very normal in the physical therapy is that the concept copper, you have a patient that is copper, yeah? what do you think that is a real copper? We know that we have a lot of studies that talking about the copper concept, and the copper concept gonna be different in the future. But what do you think? How is the typical patient that he's copper?
So that's a slightly loaded question, and only from the perspective of the copper status can be very fluid or can change. Sometimes we have individuals who are looks like they're copers or potential copers that end up having instability later on. And then we have others ones that have early instability but develop good dynamic stability later. So we have some algorithms that we've put together to try to best suit that. But at this particular time, there's no really good predictive model to say who's going to be a copper or who isn't.
Perfecto. Lo que él está diciendo es que, por ahí para la gente que no está tanto interiorizada, Copper es la persona que presenta ciertas características clínicas que puede ser potencial para un tratamiento conservador, que él dice que por ahí una persona que tiene una característica de ser Copper ahora, una persona que tiene una buena estabilidad dinámica, eso puede ser diferente en el futuro, y que al menos hasta ahora no tenemos una forma de tratar de predecir qué es lo que va a pasar con ese paciente. Si ahora no es Copper, si después va a ser Copper, o qué es lo que está pasando. Perfect, my friend. For example, you have to decide today, comparing you 10 years ago, maybe if 10 years ago a patient said to you, hey Dad, you say, I have my ACL, I have an ACL injury, yeah? You say, what do you think that is the best choice of treatment? Your answer was the same 10 years ago that now?
So 10 years ago, that's when I was in the middle of my PhD doing a lot of that study. So I would say my thoughts haven't changed that much since then. I would say 15 years ago, I would say that a lot of those individuals would need surgery regardless.
Uh-huh.
So yeah, I think a lot has changed, again, just based on the available evidence that has come out.
Bien. Lo que le está diciendo es que hace 10 años él estaba en el medio de su doctorado, entonces él estaba investigando sobre esto, que 20 años atrás sí hubiese dicho no, todas las opciones son quirúrgicas y es algo que tenemos que realizar, pero obviamente ahora hay bastante información y eso genera una desconexión con lo que sucede. Okay, Ed. Imagine that you have a patient, you have the patient that he has a very good qualities, he has a very good characteristics for try to a conservative treatment. No?
Yep.
But you have to talk with this patient. On the other side, you have a physician that the posture of the physician is the treatment, everything is surgical.
Mm-hmm.
How do you manage this situation? You talk with the physician, you talk with the patient. How do you manage? How do you do in these times?
Yeah, sometimes that's always the rub. Fortunately, I've worked with a good bit of surgeons who have adapted to what the research has shown, but others, it can be very tricky, and finding that balance of discussing with the patients what may be good options and then trying to gently persuade the physician can be a little bit more challenging in the States, because a lot of our referrals back to PT come from the physicians. Sometimes the physician just ends up doing the surgery regardless of our recommendation.
Okay. Él lo que está diciendo en su caso es que tiene una conexión de trabajo con el médico, donde hacen investigación en conjunto, pero muchas veces también lo que pasa es que ciertos colegas por ahí tienen la posibilidad de hablar con el médico y hacerle la recomendación. In our team, in KINÉ, we have the best physician in all Argentina. He's not the best physician just for the knowledge. He's the best physician because he's the most beautiful. You know that? Federico Alfano.
Uh-huh.
A big clap for Fede.
Yep.
Okay. So you have a patient that he decides he decides to the surgeon, he decides to the surgical choice. So you have to decide, in this patient, you think that maybe it's a very good choice start for pre-op, for the preoperative treatment. What do you think about the preoperative treatment? Lo que le estoy preguntando es, ¿tiene el paciente que ya va a hacer la opción quirúrgica? ¿Qué es lo que él cree sobre respecto a los tratamientos prequirúrgicos? What do you think, Dave?
Yeah, so one of the first things we try to do, again, is kind of resolve those early impairments. And so what we kind of refer to as getting a quiet knee, get the pain down, get the effusion down, get the range of motion back equal to the opposite side, and try to get their quadricep as strong as possible. Mm-hmm. Because that's the muscle that tends to be at least the most affected. We still do work with the other muscles as well, the hamstrings and the calves, but we find the quadriceps still needs to be kind of targeted the most because it tends to be the most affected.
Okay, lo que está diciendo es que sí, que muchas veces la persona antes de estar en la cirugía tiene varias situaciones, como por ejemplo una rodilla que tiene edema, una rodilla que por ahí está como inhibida y que muchas veces el trabajo y el fortalecer ciertos músculos es positivo, sobre todo hablando de lo que es cuádriceps, y también muchas veces menciona que en los isquios está bien, pero sobre todo tener un cuádriceps fuerte cree que es algo positivo. Okay, but I have other question. Imagine that it's very normal that after the surgery, yeah, you have a patient that the quads is like a quads of my girlfriend. It's very, very soft. He doesn't have strength. And what do you want about it? Mostly the role of the surgery is that the quad is close next to the surgery. But before the surgery, you worked a lot the quads, but after the surgery the situation is different. What do you think?
Yeah, I mean, most evidence still suggests the better the quads go in, the better are the quads are coming out. But there's still going to be a dip. So even if you get those quads way back up before surgery, you're still going to see a dip after surgery. But hopefully the dip is less than if you didn't do anything before.
Sí. Es lo que dice es que sí, que pasa eso realmente, que muchas veces la evidencia habla bien, pero sí que es real que muchas veces después de la cirugía la realidad es que todo lo que venías ganando antes se pierda. In these cases, you have a lot of choices for treatment. For example, you know that we have a very good evidence about, for example, the therapeutic hairs, yeah? But, for example, today I got a question from a friend from Mercedes. Do you know Federico Villalba? He's, I think that maybe he loves the float restriction, yeah? Mm-hmm. You know it?
Yep.
What's your opinion about it?
Yeah, I haven't used it myself a lot, but there seems to be some good evidence. Right now, it seems to suggest that it's beneficial. And so right now, there are studies looking at the comparison of, say, neuromuscular stem versus blood flow, because you may know neuromuscular stem can be very discomforting to patients compared to blood flow restriction.
Yeah. Do you use it in your lab?
I do not use it.
No, okay.
So yeah, but I know people that are using it and they seem to be having some good results.
Lo que está diciendo es que sí, que está empezando a haber un crecimiento en cuanto a la evidencia y en cuanto a la información con respecto a la restricción, a la terapia de restricción de flujo, que es algo que se puede utilizar muchas veces, que también esto es algo que puede generar disconfort y que depende también del paciente, que él no lo utiliza, pero sí conoce gente que lo utiliza y cree que tiene buenos resultados. That's really good, yeah? I think that maybe the last question that you have the situation that where we have to decide surgical or not surgical. Sometimes the evidence is very conflicting about how is the result of the menisc injuries in the patient that he decides on surgical treatment. What's up with the meniscus injuries next to this situation?
Yeah. The meniscus, you know, the more I think we see in the literature, the meniscus seems to be the factor that is precipitating kind of maybe earlier development of osteoarthritis. So I think, you know, especially if somebody decides on non-surgical management, their meniscus has to be in pretty good shape, but the evidence seems to show that the longer they go without surgical treatment, the higher risk they are developing a meniscus injury down the road. And I think that on the flip side, when they have surgery, there probably needs to be, again, depending on the extent of the injury, probably some surgical intervention along with it. I think if you're just looking at strict meniscus injuries, there's a lot of evidence right now as whether or not surgical versus non-surgical is the best.
Yeah.
And so I think there's a lot we still don't know which is the best, probably the best treatment overall.
Bien, está diciendo algo muy bueno, que es que básicamente la realidad es que muchas veces se trata de decir, si tenés una lesión meniscal, no hagas esto, no hagas lo otro, pero la realidad es que hay muchos factores que dependen, sobre todo, por ejemplo, del tipo de lesión que tenga o cómo sean las características de la persona o por ejemplo, la actividad. Entonces, es muy difícil por ahí tomar una decisión con respecto a esto. Ok, Dave, ok. I wanna discuss about a lot of things. I don't know if things or myths in the ACL rehabilitation, in the post-surgical ACL rehabilitation. For example, I think that maybe this question you don't like it because I thought that, or I think that in the past this question for you was, I think, a million times. But what do you think about the exercises in open kinetic chain and closed kinetic chain? Sorry.
No, that's fine.
Let me translate un segundo.
Yeah.
Lo que le pregunté es, esta pregunta sé que muchas veces es como una pregunta repetida, todo el mundo la hace, ¿cuál es la opinión con respecto a los ejercicios de cadena cinemática abierta o cerrada? Y que la debe haber respondido muchas veces, pero no puedo no preguntársela. Okay, go ahead.
Yeah. So many of you probably know my mentor, Lynn Snyder Mackler. She's very opinionated about this. My thought is, and again, just looking at the evidence, is open kinetic chain places anywhere between probably 3 to 5% of strain on the native ACL. And walking seems to suggest in some computer models, at heel strike, the strain is up to about 12%. And so the question is are we putting a lot of strain on that graft at end range? And the evidence seems to suggest it's not. And part of the flip side, I think, of that is also early on when you're going through a full range of motion and putting some strain on that graft, the quadriceps not strong enough to increase the load because it's so weak. So it's probably not loading the graft as much as we probably anticipate it is. I think the challenge is when we get to that point where the graft is healing, the quad is getting stronger, are we pushing that limits of straining the graft at end range? And it may be the point that's when we need to start straining the graft so the graft gets stronger.
Let me translate one second. Yeah. Lo que él está diciendo, basado un poco también en la opinión de lo que fue su mentora, Lynn Snyder, que lo que está diciendo es que muchas veces evaluando un poco lo que es el estrés que sufre el injerto en diferentes posiciones, por ejemplo, cuando camina o otras cosas, uno está haciendo cadena abierta y cadena cerrada, y por ahí el estrés no es tanto, que él lo que cree que el punto de discusión es cuando uno busca un rango de movimiento que pone tensión en el injerto y cuándo es necesario hacer eso, en qué parte. Ok, continue.
Yeah, so if you look at the close kinetic chains, some of the close kinetic chains put fairly similar strains on the graft as well.
Mm-hmm.
I think the flip side is in the close kinetic chain, you do have the impact of the glutes and the hamstrings, providing a little bit of that posterior potential posterior translation to protect the graft. So, but right now the literature seems to suggest that the strains are okay because I don't think I've seen anywhere where people have looked at open chain versus closed kinetic chain that actually increases the risk for graft failure.
Ok, ok. Él lo que está diciendo es que en realidad es muchas veces no varía tanto lo que es la estrés del injerto en ese caso, que si uno está haciendo una comparación entre lo que es cadena abierta y cerrada, no varía tanto ese estrés. Lo que pasa es que muchas veces en cadena cerrada lo que funcionan es que trabajan otros grupos musculares, como por ejemplo los glúteos o por ejemplo los isquios, ¿sí? Pero todo depende en qué uno es lo que piensa. Si uno piensa en lo que vendría a ser el estrés en el injerto, no es tanto una discusión cadena abierta y cerrada, sino que qué grupos musculares uno querría trabajar. You hear me, yeah?
Yep.
Yeah, yeah. What about Shores? Shores is good?
What?
Shores. The dog. The doggy.
Oh, Jorge.
Jorge.
Jorge. Jorge is good. Yeah.
Jorge es el perro de Dave.
He's
Oh, he's very good.
yeah, he's sitting on the couch, looking outside, ready to chase squirrels.
Nacho all the time, I think I maybe all the time say that he missed a lot. Sure.
Yeah, yeah.
Okay, let me continue. You're okay? How's you feeling? Good?
Yeah,
Yeah, you relax?
yeah. I'm good.
Okay.
I'm good.
I'm better. Okay, continue with the topic of discussing. I think that maybe sometimes we have to assess strength in these patients in the post-surgical rehabilitation. What do you use in these cases? For example, we know that maybe in the last part, in the return to plane, we have to use maybe the isokinetic machine for assessing it. But for example, in the early times, what do you use? You use a handheld, you use other tool, other device?
Yeah, I mean, we still in our lab, we still use the isokinetic device, isometric. We tend to do more isometric, but again, we're probably a little bit, I think, more conservative with our testing than we are with our training. But the Norwegians do isokinetics, and they'll do the isokinetics through a fuller range of motion. But I think, if you have an handheld dynamometer, again, doing it at 60 degrees, again, produces no strain on the graft, and it's the best length tension relationship for the quad. So it probably gives you the best data.
Okay. Él lo que dice es que sí, si teniendo por ahí la posibilidad de tener un dinamómetro de mano, puede evaluarlo, no generando un estrés alto en lo que vendría a ser el injerto. Que, por ejemplo, los noruegos, ellos sí evalúan con isocinesia independientemente del tiempo, solo cuando tienen el rango total del movimiento, pero que él prefiere utilizar un dinamómetro de mano. Okay. For example, you have a patient that the evolution is really good. You have to decide when he starts to run.
Mm-hmm.
What do you think is the consideration for start to run?
Yeah.
Which criterion?
Yep. So we will consider somebody kind of on an early kind of walk jog program at around 12 weeks. And again, usually we want to make sure they're going to have very little swelling in their knee, really no pain, no patellofemoral pain, no pain in the joint. full range of motion, and around about 70% quadricep strength. We feel that seems to be at least adequate enough strength to start people. And again, we're pretty conservative with our walk to run program. Well, we may do a track, like a 400-meter track where they jog the straights and walk the corners to start with, and then slowly progress them.
Ok. Él lo que dice es que obviamente para poder empezar a correr, hace un programa de 4 semanas de lo que vendría a ser muchas veces caminar, no tiene que tener ningún tipo de dolor de paciente, ni dolor femoral por ejemplo, y también obviamente tiene que tener un porcentaje de fuerza a nivel del cuádriceps, que él habló que fue del 70%. Ok, for example, you have this case, the patient has just 1 month, yes, 1 month post-surgical. What is your decision? You start to run or no?
So if they just have one month under their belt, no, we don't allow them to run yet. And again, some of it is, you also have to allow the graft, some healing time as well. And again, I think that's probably why we wait to the 12-week mark or to 3 months, is to allow some graft healing as well as allow some of the strength to come back.
Bien. Él lo que dice es que no, que si el paciente, yo lo que le pregunté es si el paciente estaba bien, tiene todas esas condiciones que él mencionaba y por ahí tenía un mes de postquirúrgico, si se iniciaba a rehabilitar, y él dice que no, que probablemente considera también un poco lo que es el tiempo del injerto y cree que más o menos un tiempo sería hablando en 3 meses. Okay, Dave, thanks for these topics, and we continue with maybe, I think that maybe, about the sports science.
Yeah.
Yes. Today, for example, in all the world, some words, some topics like prevention, like return to play, like training a lot. I think that maybe that's the trend topics, because everybody love speak about it. Yeah.
Yeah.
Obviously, I have some question for you. Yeah. Okay. You think that maybe it's wonderful that you work and you keeping in touch with a lot of research that's really important in the ACL rehabilitation with you, obviously. For example, you talk with Dean Snyder, you did research with Griden. I mean that the research of Griden was maybe was a point for change the paradigm in the return to play in ACL rehabilitation. Yeah? What do you think? Le pregunto, 1 second. Lo que le pregunté es, él trabajó con muchos investigadores muy grosos de rodillas, llámese el caso de Griden, llámese el caso de Dean Snyder. Yo creo que por ahí algo que cambió un poco un paradigma fue el trabajo de Griden, porque empezó a hablar de los 9 meses, que no teníamos que volver a los 6, sino que los 9 meses, y había diferencias significativas en los 3 meses previos. What do you think about this work and about the concept, about the time in the return to play these days?
Yeah, like you said, it's a hot topic for sure. And the work we've done with Norway, we have very, very strict return to play guidelines that include performance-based measures and patient-reported outcome measures that allow us to gauge those 2 kind of domains. And we've seemed to found, at least with our data, that the risk continues to go down to about 9 months, where other people are finding aren't finding the same things we are. And I think that's some of the challenge is its predictability versus its ability to, at one moment at time, capture somebody's performance.
Ok, lo que dice es que sí, que el estudio que fue la corte de la Oslo, Noruega, marcó como si fuese una tendencia en cuanto a lo que es el tiempo, pero cree que el desafío más que nada pasa por decir si esa persona cumple con los requisitos de predicción para saber si va a volver, puede volver o no, y si obviamente tiene un riesgo. Okay, Dave, for example, you know that we have a very good battery battery of tests. Obviously, for the return to play, we have a hop test, we have a strength, we have the time. And for example, that's an atypical case that you don't have time. Yeah, you don't have time. You have a patient. You have to take a decision for do just 3 tests. What do you think that the main 3 tests for return to play in obviously in ACL rehabilitation?
Yeah. So I still think quadricep strength is really important. From our data, and this wasn't return to sport or return to activity, but it was looking more at knee function. We actually found that the 6-meter timed hop was the most predictive. And for determining whether or not somebody was actually going to do poorly. And then I think also using a patient-reported outcome measure. And again, we kind of like the IKDC, even though the KUS is the one that we found that we use in our test battery. The IKDC captures a little bit more information than that.
Okay. Lo que yo le pregunté es que obviamente hoy en día tenemos una batería enorme de test para hacer en un paciente que está volviendo a la actividad. Muchísimos test tenemos. Obviamente ya se sabe, pero por ejemplo él tiene que tomar una decisión, no tiene tiempo y tiene que hacer solo 3 pruebas. ¿Cuáles son las pruebas que él cree que lo que es la vuelta al campo considera las más importantes? Entonces habló que dice que la fuerza del cuádriceps es realmente muy importante y habló sobre todo de lo que tiene que ver un test de hop test de 6 metros, ¿sí? Es saltar con un pie en 6 metros. Y también habla acerca de lo que es la función autorreportada. Eso muchas veces acá somos bastante vagos con los cuestionarios. Ellos lo buscan, tratan de ver qué es lo que reporta el paciente y cree que eso le da muy buena información para tratar al paciente. That's really good. You know that I think that maybe that's a cultural difference, but in Argentina I think that maybe except some population, except some physical therapists, we are not really good in do the self-report measures. For example, we have just validate the lower extremity functional scale. We don't have other scales. Obviously, you remember the ASES. Yeah, I remember. So that's a really good point. I think that maybe your message is really good for us. Yeah, it's really good because I think that maybe we can do better. We can do better. Yes? Okay. What do you think maybe you have a patient and the patient is in the context that return to play? You decide to do the different tests, for example, the hop test or strength test, and you need to decide with fatigue or not fatigue. Yes? What do you think is the role of the fatigue in these patients? Yes?
I'm sorry, the what?
Yeah, fatigue. F-A-T-E-G-U-E. Fatigue. Fatiga.
Fatigue.
Fatigue.
Yeah, fatigue.
Thank you.
Yeah, no.
I have
well, there's you like to talk about controversial topics. That one's probably even more controversial than the upper and the upper kinetic chain. Because Tim Hewitt will say fatigue doesn't play a role because by the time that they're fatigued, they can't produce a high enough absolute load to create the injury. Though some people will say it's probably they're not looking at the absolute load, they're looking at more of the increased or the decreased neuromuscular control. So maybe more increased valgus or less knee flexion. And there's been a couple of recent studies that have come out that showed fatigue does play a factor. So it'll be interesting to see how that reconciles. It's hard to say from from an anecdotal standpoint, I've seen both. I've seen people get hurt early on, and I've seen people get hurt late.
Okay.
So it'll be interesting to see how this plays out. But intuitively, you think it plays a role, right, because of that. But biomechanically, I'm not sure how much of a role it does play.
Okay. Él lo que dice él lo que dice es que dice que es un punto muy interesante para discutir, incluso es más polémico que hablar de lo que es cadena abierta, cadena cerrada, que hoy en día están aumentando los estudios y se cree que por ahí cuando una persona tiene más fatiga aumenta la carga, aunque biomecánicamente es controversial. A veces sí y a veces no, por lo cual es un tema un poco polémico para discutir, ¿sí? Okay, I have a question of Nacho, because Nacho sent me a lot of questions. Nacho,
I'm sure he did.
yeah. And Nacho, you know that Nacho, I think maybe loves the quality of movement. Yeah, I don't know. It's a joke. But the question of Nacho is, what do you think about the quality of movement in the return to play? La pregunta es, ¿qué es lo que opina con respecto a la calidad de movimiento en lo que es la vuelta al deporte? Yes.
Yeah. From a motion analysis standpoint, with the technology, we can get a good idea what people's motion looks like. And again, probably try to understand how fatigue impacts that. From a clinical point of view, there's a lot of nuance to it. When we see somebody who has really poor movement, you know it when you see it. But when there's more nuance to it, or the movement's smaller, it's really hard for us to pick up. And after you kind of explain that to everybody,
yes.
I'll give you a little insight of some things I learned from motion analysis.
Okay, lo que dice es que una cosa es lo que puede pasar en los laboratorios y otra cosa es lo que puede pasar en su clínica. Entonces, como, okay, but for example, you have that, I don't know, but you have a lot of schools, you have a lot of people that they are defenders, for example, some concepts about the quality of movement, and all the time he's saying the patient, you have to control the valgus, you have to control your trunk. You think that is important, for example, in the ACL rehabilitation?
Yeah, I do think that's important. And again, I think when you see it, you know it's wrong. But for the example I was going to give, one thing I learned from biomechanics is when we were looking at people post ACL injury during gait, when we only did motion analysis on those people that looked like they had normal gait, but then when you put them under the cameras, you could actually see the differences only under the cameras. Okay. And you really couldn't see it visually. Okay. So I think when you see somebody that has really abnormal movement, you can correct it. It's when the variance becomes a lot harder to see. It may be clinically meaningful, but we can't change it because we can't see it.
Okay. Lo que dice es que muchas veces ven esas anormalidades en cuanto a la cámara y por ahí en un contexto que es diferente y por ahí el desafío pasa en ver si realmente podemos cambiar eso. And for example, you have a patient that the quality of movement maybe is not correct, yeah? You decide that you try to introduce in the patient for the different exercises for change the quality of movement. For example, in this case, you think that maybe we have very good tools like, for example, external external focus, yep. For example, feedback. What do you think?
Yeah, I mean, Ali's done a lot of great work looking at the principles of motor learning and using external cues and external focus versus internal focus. And I think that's huge on changing quality of movement and also changing motivation and improving performance. So I think that's a huge factor that I think we're starting to see the benefits from people who are starting to do some more of these neurocognitive studies as well.
Ok. Él dice que sí se puede utilizar por ahí diferentes estímulos externos con la idea de mejorar el control motor y que eso tenga un impacto en la calidad de movimiento, pero lamentablemente hasta el momento no hay por ahí tantos estudios que digan que esto lo pueden lograr, porque los que están publicados, por ahí la calidad metodológica no es la mejor. That's a really good point. That's a really good point. I think that maybe talking about the ACL rehabilitation is really exciting now because you have a lot of topics for discussing. Yeah.
Yeah.
And I had an own. Bueno, vamos a ver si ahora podemos conectar, ¿eh? Bueno, estamos esperando que nos envíe la info. Disculpen a todos por las molestias. Okay, Dave, you are, yeah. Please send me the invitation and I'm gonna accept. Please, but send me the invitation. You did it today, but then I don't know. Okay, Dave, you are inside, but now send me the invitation. Gracias a todos los que se han